Uh, as kidney diseases continue to rise globally, home dialysis is, of course, increasingly being recognized for the flexibility, autonomy, and the improved quality of life it can offer those who are undergoing dialysis. Around the world, many countries have made significant strides in adopting and expanding home-based therapies. And today we are going to, in this masterclass, explore the international landscape, primarily the US, because Dr. Mala Sachdeva is from there, what's working and what innovations are shaping the future. We will also take a closer look at the Indian context. What are our on-ground challenges, infrastructure gaps when it comes to home dialysis, and most importantly, the lived reality of someone who's been on home dialysis for many years. So without any further delay, I would like to introduce our first speaker. One second. Dr. Mala Sachdeva. She is a professor of medicine at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, and a full-time faculty member in the Division of Kidney Diseases and Hypertension at Northwell Health in Great Neck, New York. Dr. Sachdeva joined Northwell's Division of Nephrology in 2008. She currently serves as medical director for several home dialysis programs, the peritoneal dialysis program at Julia and Israel Waldorf Dialysis Center, the home dialysis program, including both home dialysis and peritoneal dialysis at the Floral Park, and the home dialysis program at the Stern Family Center for Rehabilitation. Her clinical focus includes women's health and kidney diseases, with a particular expertise in obstetric nephrology. She is the co-editor of the textbook Obstetric and Gynecologic Nephrology, Women's Health Issues in the Patient with Kidney Disease. Her research interests span home dialysis, hemodialysis, peritoneal dialysis, renal ultrasound, and women's health and nephrology. She's been very actively involved with Women in Nephrology, WIN as it's called, since 2020, serving on the Executive Council, leading the mentorship program and co-leading the Speakers Bureau. She was president-elect in 2024 and is currently serving as the president of World Women Nephrology for 2025-2026. Over to you, Mala. Thank you so much. I know it's really early for you there in New York. Thank you so much for joining us today.
Thank you so much for inviting me, Dr. Kumar and NATCO and MOHAN Foundation. It's my pleasure to be here, and I'm really looking forward also to listening to Kamal Shah's talk on, his journey and his experience as well. So with that, I will share my screen and begin my talk. Okay. So what I'd like to discuss today is I'd like to go over the type of home modalities. I'd like to discuss the benefits of home modalities. I'd like to discuss challenges of home dialysis. And it looks like there are a lot of challenges, but I can guarantee you one thing, that yes, we can overcome all these challenges. So we can actually we'll actually discuss the technical, the training and educational challenges, the physical and emotional burden challenges, home environmental issues you may have with home dialysis, support system issues, financial challenges, and medical challenges. And then we can discuss a little bit about overcoming these challenges and how we can make home dialysis possible.
And as your volume is on the highest,
Okay, hold on. How's that?
We can hear you, but it could be more.
Yeah, that is the highest it is.
Yeah, okay, that's better, I think.
Okay.
Okay, thanks, sorry.
Okay, no problem. So just discussing, chronic kidney disease has 5 stages, 1, 2, 3, 4, 5. And how we do it here in the States is when someone is at CKD stage 4, which means the kidney function is less than 30% and they're progressing, we send them for what's called pre-end stage renal disease education, where they are given all different modality choices. They're educated on modality choices and where they're going. And when kidney function is less than 20, we are hopeful that they can be transplant candidates, and we give them a transplant referral. So a lot of times, transplant is the preferred option after end-stage renal disease, or when the kidney disease is progressing. But if donation or transplant is not an option, or for example, in the United States, especially in New York, there are different waiting times for deceased donor kidney. And if it's going to take a long time to get a kidney on a waiting list, then of course you have to think of different options for the patients whose kidney disease is progressing. So you would think of home dialysis modalities, in-center hemodialysis, or if someone chooses neither, you would think of palliative care options. There are two types of home modality options. There's peritoneal dialysis and there's home hemodialysis. And I'm going to briefly touch on each one of them. So just in case you don't know what each one is, there are two types of peritoneal dialysis. There's continuous ambulatory peritoneal dialysis, which is CAPD and uses manual exchanges. And there's automated peritoneal dialysis, which uses what's called a cycler. And I'll go into that. So which one is more appropriate for you, or which one is more appropriate for your patient? And it all depends on their lifestyle and what they want and choose. So what is continuous ambulatory peritoneal dialysis? And it's just as it says, the word says. It's usually continuous, where the patient does multiple manual exchanges. So essentially, they're infusing dialysate into the abdomen. The dialysate will stay in their belly for about 4 to 6 hours, so they're not connected to anything. And then after 4 to 6 hours, they allow the dialysate to drain out. So that 4 to 6 hours gives them a little bit of that free period of time to go about and do what they want to do. So these exchanges are usually done manually, and the patient is usually doing about 3 to 4 exchanges a day. So usually 3 in the day and 1 long one at night. And then in 1981, we had the development of what's called our cycler. And the cycler made it easier for patients to stop doing manual exchanges in the day, go along with their life, and perhaps being attached to the cycler at night, which then does their dialysis for them. So typical cycler time is usually around 8 to 10 hours. And what the cycler does, and there are two types of dialysis that you can do with the cycler. What the cycler does is it fills and drains and fills and drains and fills and drains you during that long period of time without the patient doing manual exchanges. And the two types of this dialysis through the cycler would be what's called CCPD. And the only difference between CCPD and NIPD is that the CCPD requires the patient to be left off with some fluid in their belly because they may need more dialysis in the daytime, but they're not connected to the machine in the daytime. And the NIPD, which is more nocturnal, the patient is left without fluid in their abdomen in the daytime, and they can also go about doing their work in the daytime. And then there's home hemodialysis. And there are different types of home hemodialysis, and it depends again on the patient's quality of life. So if the patient chooses not to go on peritoneal dialysis, or the patient is, let's say, for example, on hemodialysis in center and wants to convert and has access and wants to convert to home hemodialysis, or the preferred method of dialysis by the patient and the physician is a home hemodialysis method, then we choose home hemodialysis for the patient. And here the patient has two choices. One is they can do short daily treatments, so usually around 4 to 5 treatments a week, 3 to 3.5 hours every treatment. And you might wonder, oh, well, this sounds like it's a little more than in-center hemodialysis, but that depends on all the clearance and the dynamics and the different machines, and that's what determining this. But on the other hand, think about it, it's in the luxury of your home. And then there's nocturnal hemodialysis. And nocturnal hemodialysis, usually in a center at night or at home by the patient, 4 to 6 days per week, 6 to 8 hours a day. So there are some differences between peritoneal dialysis and home hemodialysis. And here are the differences. In terms of frequency, so peritoneal dialysis usually is done daily, but when we do start, and we'll discuss that, we do have the benefit of starting incrementally. So there's something called incremental peritoneal dialysis. And then you have home hemodialysis, which we were just talking about, could be nocturnal, could be short daily treatments, 4 to 5 times a week. With peritoneal dialysis, you may or may not require a machine, right? So we talked about doing manual exchanges with CAPD, or you need the machine, which is the cycler. And with home hemodialysis, you need your dialysis machine. You have to be careful because you need good water supply. For home hemodialysis, you usually need good water supply. For peritoneal dialysis, you don't need a water supply because everything is with bags. There is good flexibility with both of them, and hence the quality of life, there is a big benefit to that. Training duration for both differ. So with peritoneal dialysis, the training here in the US is about 7 to 10 days, and you teach every patient to do manual training first. And then if they choose cycler, then it's an additional 2 days of training on the cycler. But it's not written in stone. For example, if a patient is a fast learner, it may take a little bit less days. If a patient is a slow learner, it may take more days. And we don't send a patient home unless they're absolutely confident and know how to do it. And with home hemodialysis, it's a little different because it's more intense with the training and the access and so forth and the cannulations. The training takes typically around 4 weeks and sometimes can extend out to even 6 weeks. The access, which is how do you do the peritoneal dialysis and how do you do the home hemodialysis for the patients? For the home hemodialysis, it's the same as in-center hemodialysis. We prefer a fistula in the arm. For the peritoneal dialysis, usually 2 weeks prior to starting peritoneal dialysis, the patient gets a peritoneal dialysis catheter placed by a surgeon. So let's talk about the benefits of home dialysis. And there are many, and this list can extend past many, many slides. So the benefits of home dialysis, as we talked about a little bit earlier, are you get a greater flexibility with one's day-to-day routine. So your patients can go to work, your patients can go to their appointments. There's more independence regarding the timing of dialysis and when they can start dialysis. So for example, they may not choose to do it every day at the same time, but as long as they're doing it in their specified hours, that's what counts. So they have better quality of life. It leads to a better lifestyle. With home hemodialysis, there are a lot of other medical benefits which have proven through evidence. So these benefits include better and fewer dietary restrictions because you're doing almost daily dialysis or longer dialysis sessions in these patients. And so they tend to have lower phosphorus levels. They tend to come off their phosphorus binders. They tend to be able to liberalize their diet and eat more phosphorus foods. They tend to also have better blood pressure control. And with the better blood pressure control, better fluid control, they're able to come off a lot of their blood pressure medications. There are a lot of heart benefits also with nocturnal hemodialysis or home hemodialysis. And it has been shown through different evidence that patients tend to have better and improved left ventricular function, left ventricular hypertrophy, and so forth. So there are a lot of benefits to doing home hemodialysis medically. And then you think about clinic visits, right? So you think about usually on average, our home hemodialysis and peritoneal dialysis patients are coming about 2 times a month. The first visit is for their monthly blood work and the nurse visit. The second visit is to go over the blood work with the physician and with the team and to get any other medications that they need to get in the clinic. So usually 2 times a month is a requirement. And then, of course, if they need to come anytime sooner or later or more frequent, we do it. The other benefit is you're doing it in the luxury of your home. And another benefit is travel. So a lot of my peritoneal dialysis patients and my home hemodialysis patients find it easier to travel, rather than those patients that are being in center. And think about it. If you compare this to in-center hemodialysis, you're talking about 3 times a week dialysis in a center. So the patient goes 3 times a week, at least 3.5 hours every session. But it's not only 3.5 hours every session. Think about the time it takes for the patient to get to the dialysis unit. Think about the time it takes for the patient for everything to wrap up and the patient to leave the dialysis unit and go home. That's a good 6 hours of your day, approximately 5 to 6 hours of your day. And that can take a toll on a patient's lifestyle, on a patient's independence, and the patient themselves. So there are a lot of benefits, like you can see with home dialysis. The other benefit is we have seen a difference in terms of patient survival with peritoneal dialysis versus versus in-center hemodialysis. And that difference we've seen usually in the first 3 years of starting peritoneal dialysis, we see that patients tend to have maybe even a better survival on peritoneal dialysis for those first 3 years. And the thought is maybe that they still have their urine output and they're able to maintain their urine output on home modalities or home peritoneal dialysis more than they can with hemodialysis. And the other benefit actually of peritoneal dialysis is doing what's called incremental PD. So we don't do one size fits all. We actually, when a patient starts peritoneal dialysis, we're able to individualize their prescription, their peritoneal dialysis prescription to them and how much they actually need at the beginning. So this is not a new concept. And what we do is we take into account their residual renal function. So residual renal function is their urine output. So at the beginning, even if the kidneys have failed, some of our patients are still having urine, and that urine counts for their prescription. So if they have a large amount of urine output, their PD prescription at the beginning may be this much. But as the urine output goes down, the PD prescription will go up. But this is what we call incremental peritoneal dialysis. So when they start peritoneal dialysis, they're actually started very gently with a very low prescription, making things much easier for them than starting full force. So typical peritoneal dialysis incremental prescriptions could include even just doing 1 exchange a day, doing 2, and then increasing to 2 to 3 exchanges a day for manual exchanges. For the cycler, however, we've even done 4 days a week, 3 days a week, and not daily treatments as their urine output allows. So this really takes into account their clearance from their residual renal function or their urine output clearance and allows the patient to have a very low prescription at the beginning, yet it is enough that they need. And the outcomes with incremental peritoneal dialysis show that it's a very feasible technique. The quality of life is better preserved. It increases the rate of choice of PD as the modality of choice, and it's better to use at the start of peritoneal dialysis. It is very well accepted by patients and staff. I mean, think about patients doing 1 exchange a day as opposed to 4 exchanges a day. And it's a very good option for elderly people who do require assistance from another person to perform their exchanges. So the beginning is much easier for the caregiver than later on. And it allows flexibility for individuals also who have an active lifestyle. For example, I have patients who are working, and if they're able to do 1 exchange a day at the beginning, they work, they come home, they fill their abdomen, they disconnect, go to sleep. In the morning, they drain, and that's the 1 exchange a day that they're doing. And that might just be enough. But every modality comes with challenges. And here I'm listing all the challenges. However, we have to know that these challenges can be overcome. So some of the challenges include the technical challenges, they include the training and educational challenges, the physical and educational and emotional burden challenges, the home environmental issues, support system, financial challenges, and medical challenges. And we'll touch upon each one. When I talk about technical challenges, we think about the machine. So your patients might have problems with setup of the machines. But how do you overcome that? They're taught what to do if there is an issue. The machine may alarm, and they are again taught through looking at the manuals, which are very straightforward, how to overcome the machine alarms. And if they continue to have problems, there's a 24/7 Baxter and Next Stage assistance, which helps them troubleshoot every machine alarm or technical challenge that they can have. Then there's maintenance of machines. So usually what happens is the machine alarms when servicing is needed. Patients can call the company if they need some maintenance, if they need a new machine, they get a new machine right away. There's risk of equipment malfunction. Again, patients might wonder, what do I do if I can't do dialysis that certain day? And again, there's 24/7 nursing staff available to advise them what to do. There is the need for electricity if you have a home hemodialysis machine or if you have the peritoneal dialysis cycler. So what do you do if the power runs out? Again, patients are instructed if you're on peritoneal dialysis and the power runs out, there's a certain amount of time that they have, 90 minutes, where if the power is restored, great, it continues. If not, they're taught how to continue with manual exchanges and drain. With home hemodialysis, question is, can you skip that day if you're not doing daily? And if you can't skip that day, they're taught how to use bag dialysate. Then there is need for good water supply. So home hemodialysis especially needs the good water supply, and there is monthly water testing that's done for different minerals in the water. What about the training and educational challenges? So, as we talked about, there is extensive training for both the patient and or the caregiver if there is a caregiver involved. And so this training for home hemodialysis, as we talked, was about 30 days, so 4 weeks to extending out to even 6 weeks if needed, and around 7 to 10 days for peritoneal dialysis with an additional 2 days of cycler training. So then you talk about patients need the time off from work. And usually here in the US, it's not an issue. Ahead of time, they're applying for either short-term disability or they're taking the time off from work. But it's not only the patient, it's also the caregiver who may need that time off from work. Then we have a variability in learning ability for the patients. So everyone's different. Everyone's learning style is different. We can have patients who learn quick, patients who learn slower, and that's okay. Every nurse is, God bless their patients, they're patient enough to work with every patient's learning style. And we talk about language barriers with training. And language barriers, I can tell you, have been overcome as well. We have patients who speak all different types of languages, from including Spanish, Russian, And our nurses are able to teach them in their language with either a translator or somebody from Baxter or Next Stage who can translate, and it really hasn't been a big issue. Then there's literacy barriers with training. But again, I can tell you, if the patient cannot read, we can actually help them with that also. But if the patient is not literate, it's still okay. It's easy to learn peritoneal or home dialysis. And then there's the fear of making mistakes. But of course, as time goes on, patients will become more confident. What about the physical and emotional burden and barriers? So there's always the fear and anxiety of managing the treatment alone. But our patients are always told that the nurses are available 24/7, that there's 24/7 assistance from Baxter or Next Stage, which are the suppliers of the machine. There's always fear. What if they need help? There's fear of making mistakes. And again, like I was saying, they're reassured that there is backup. And what about if there's a complication on the machine? Patients are afraid, how can I handle them alone? Again, reassured, go through the technique. If this happens, if that happens, if there's a blood leak alarm, if blood pressure drops, if you notice something happening, what do you do and how to handle it? And they're taught in every single complication and how to deal with it. The only other question is, does the patient feel isolated during dialysis at home versus in-center where they're surrounded by a lot of other patients doing dialysis? But in fact, the studies have shown that the home modalities, patients have a better quality of life because they're doing it in the setting of their home. And then because of the isolation, are the patients getting depressed? Maybe we're not seeing our patients that often and we're not able to see if they're getting depressed. However, with the social support system of being at home, it may provide a better explanation and a better treatment for this. And then there are home environment challenges. So the home environment challenges would be that if you're doing dialysis at home, is there concern for any change in family dynamics? Are you putting a burden onto family, or is the family seeing what's going on and just being, sometimes it could be a positive thing and they're just, they're more empathetic, but sometimes it could be a negative thing and it takes a toll on the family. What about privacy concerns? So there's some of our patients who don't want to bring dialysis at home, and that's still okay. Maybe home dialysis is not the right thing for them. Then with home dialysis, you need a dedicated space and setup at home for the treatment itself. So think about it. You need the space for the machine, and you need to consider where you will do the dialysis at home. But you also need some storage space for supplies. Usually, again, not a big issue. Then you need the clean space for dialysis, and you need a sterile space for dialysis and its supplies. And the patients are taught how to maintain the cleanliness of the home environment for making dialysis optimal. There is a requirement. So since the home dialysis is done at home and there's a requirement for sterility and access of supplies, it usually means that the patient, wherever they are, needs to come back home to do their dialysis. And what about the support system challenges? So the patients may wonder, do I need a caregiver? For the most part, you don't. Except if you're elderly and you can't do it yourself, or if you have a very hard access for home hemodialysis where you may need somebody to help you cannulate your fistula, for example. But for the most part, for peritoneal dialysis, the patients are usually taught to do it themselves. When I do have elderly patients, they have a family member or a caregiver who learns the dialysis for them. And the same goes for home hemodialysis. But then you talk about are you causing any caregiver burden? And this is the biggest challenge, I think, of home dialysis where there are caregivers. So, for example, with peritoneal dialysis, if a relative or caregiver is performing the exchange, the frequency of exchanges where the caregiver now has to take the time and fill the patient and then drain the patient might pose a burden onto them. And you can imagine if you have 4 exchanges a day and the caregiver has to fill and drain and fill and drain 4 times, that can pose a burden that the caregiver needs to be present at those certain points in time to do the peritoneal dialysis. And with the home hemodialysis, it can pose a problem if the patient has to be cannulated or there has to be a caregiver present at the whole treatment of the home hemodialysis. But some patients may not have family support, some patients may not have a caregiver, but that's still okay. Then there are financial challenges, and the financial challenges include the cost of the equipment. For the most part, the cost of the equipment and the cost of supplies for us in the United States is covered by insurance. Prior to a couple of years ago, we could not put any uninsured patients on peritoneal dialysis. In New York and some other states, we have overcome that with emergency Medicaid. Then there's caregiver, right? So is the caregiver or the patient, are they losing income because they have to take that time off from work to either do the dialysis for their family member or friend, or is the patient having to take time off from work because of their illness and losing income? So these can be actually the bigger challenges. Then there are the medical challenges. What about the risk of infection or peritonitis with peritoneal dialysis? Or the risk of access infections or bloodstream infections with home hemodialysis? Patients, I can guarantee you, are taught to be very, very careful, and they're taught how to avoid these infections. So if they're doing everything correctly as they should, they really shouldn't be getting these type of infections. There's peritoneal dialysis, which might have a limitation in how much fluid a patient can put in their belly. So they might start feeling uncomfortable if they start having to put more fluid in their abdomen. And then with home hemodialysis, there might be the challenge of having limited access, vascular access, so fistula, graft, catheter access sites for home hemodialysis. So who is a good candidate for a home modality?
So 5
For
minutes,
me,
Mala?
sure,
Another 5 minutes? Yeah.
perfect. So for me, it's almost anyone. As long as you're motivated, as long as you're able to learn, as long as you have a stable home environment and somewhat of a support system, and the physician recommends you for a home modality, you're a good candidate. Our patients, to overcome challenges, like I was saying, there's home training programs, home centers, which train the patients. There's 24/7 nursing support, 24/7 technical support. There's equipment gets delivered very, very quickly within overnight if there are any issues, and the patient education is ample. So what can we do? Just keep supporting and educating patients on home modalities. So in conclusion, home dialysis is a safe and effective option for all our patients. It offers independence to our patients with a lot of potential health benefits, especially with home hemodialysis. And you have to work with the care team to choose what's right for you. There are challenges and a lot of challenges, but these are not major challenges and they can be overcome. And I think everyone should consider starting a home modality if transplant is not an imminent option, and if unsuccessful, then change to an in-center hemodialysis. With that, I'd like to say thank you, and I'll stop
Thank you,
sharing.
Mala. That was a very, very, very thorough and very comprehensive presentation. I can see a lot of questions in the chat box, but I would like to bring in our next speaker. I think a lot of what he discusses, along with what you've said, should answer some of those questions. Very, very privileged to have with us Kamal Shah, Kamal, as you all know, we've shared earlier, has been on dialysis for the past 28 years, continues to live a fairly full and active life, certainly more full and active than mine is, as what I heard last time. Works full time, swims every morning, travels extensively, defying the limitations that are often associated with dialysis. In the year 2009, Kamal co-founded NephroPlus, which is a leading chain of dialysis clinics, along with a healthcare strategy consultant, Vikram Bubula. And today, NephroPlus operates in 5 countries with around 500 clinics, making it one of Asia's largest dialysis networks. He documents his personal journey and insights on dialysis through his blog, kamaldisha.com, offering guidance and inspiration to fellow, I don't think you like to use the word patients, fellow dialysis users. He also a TEDx speaker and the author of the book Silver Lining, wonderfully written book. I had the privilege of reading it, and I highly recommend it to the others. It traces his journey from being diagnosed with kidney failure to co-founding NephroPlus and transforming the dialysis landscape in the region. Over to you, Kamal.
Thank you so much, Pallavi. Just share my screen. You can see my screen, Pallavi?
Yes, we can.
Awesome. So, first of all, thank you so much, Pallavi, for inviting me to give this talk. And thank you so much, Dr. Sachdeva, for a wonderful talk. Like Pallavi said, I think it was very comprehensive and informative. Coming to the Indian context, I'd like to talk a little bit about how home dialysis is different from the developed world in terms of home dialysis. So first, a quick history, my medical history. I was diagnosed with a rare disease called atypical HUS in July 1997. I was on hospital-based hemodialysis for about a year and a half. And then I had a failed kidney transplant my mother donated. I was in peritoneal dialysis soon after for about 6 years. And then on daily nocturnal home hemodialysis from 2006 to 2022. And for the last 3 years, I've been doing daily nocturnal home hemodiafiltration. And I'll talk a little bit about what these therapies are. Some of them may not be familiar. So I think the biggest challenge for home dialysis, especially in India, is the lack of awareness. Typically, what happens is, once somebody gets onto dialysis, and in India, unfortunately, we don't have patients who get diagnosed in the early stages of CKD often. Of course, it does happen in pockets, but a vast majority of the patients, they crash land into kidney failure, where they were not aware that they had kidney disease for the longest time, and suddenly their symptoms become unbearable, and they have some adverse event, and then they land up in the hospital, and realizing that their kidneys have failed. Now, in those circumstances, what most of the time what happens is there is a bunch of tests and so on that happens, and then the doctor tells them your kidneys have failed, you need to get a fistula for your dialysis. And so the patient is in so much shock that their entire life has turned upside down. The whole family's life, in fact, has turned upside down. And there are ideally the way it should happen, and I think the way it happens in much of the developed world is that there are counseling sessions held by the doctor and the medical care team with patients who are in early stages of CKD, typically stage 3, stage 4, when the various options for renal replacement therapy, as it is called, that is treatment options for kidney failure, are begun to be discussed. So you are told about hemodialysis, you're told about peritoneal dialysis, you're told about home hemodialysis, you're told about conservative therapy, about kidney transplant, of course, and you are counseled about what are the advantages and disadvantages of each option, and then you're allowed to think, you're allowed to meet patients, discuss with your family, and then come up with a decision in terms of which modality you would like to opt for. Like I said, in India, unfortunately, that doesn't happen a lot of the time. It happens in a few pockets, like I said, but a lot of patients, that whole counseling session does not happen, and then they just by default put on hospital-based or in-center hemodialysis. Coming to my situation, so like I mentioned, I had a failed kidney transplant in 1998 November, and I was very disappointed because I thought that the transplant would be the end of all my problems. But then when it didn't work out, within a few days, I had to be back on dialysis after the kidney transplant due to recurrence of my primary disease, atypical HUS. I started researching on the internet about treatment options and about how I could get my life back, and it was on the internet that I found out about peritoneal dialysis. And that's why I say peritoneal dialysis, unfortunately, is nephrology's best kept secret. I really liked that therapy, because it gave me a lot of flexibility, and I'll come to what I liked about it in a minute. But uh, among the entire nephrology ecosystem, in India, PD is unfortunately looked at as like a last resort, for it is used where hemodialysis is not going to be possible. So, for example, patients who have poor accesses or access, the veins are too small to get a good fistula, or patients who don't stay close to a dialysis center, a hemodialysis center. So, for it is used as an option when there is no other option, so that is the unfortunate reality about peritoneal dialysis. Now, there are some reasons that could be that why is this, some many times I think that why is PD not as why are people not aware of PD, why are they not told about PD? uh, I have spoken to doctors about it, other patients and so on, and many doctors, they feel that, I think, in their medical training, in their uh, programs of medicine and nephrology and so on, not enough focus is probably given to peritoneal dialysis. And the doctor's reimbursement also compared to hemodialysis is lower on peritoneal dialysis. There are some patient related aspects as well. Many patients, they don't like taking ownership of their treatment. Now in peritoneal dialysis, you are going to be the person who is responsible for your care. The patient is the one who is responsible for their care. Some patients are reluctant to do that. They feel it is too overwhelming for them to take ownership. They just prefer going to a center and putting their arm out and getting the technicians and the nurses to take care of them. There are also hygiene challenges in certain areas in India where, let's say a Bombay-based patient told me once that in Mumbai, the houses are generally smaller. I mean, for let's say a middle class family, it's not as Bombay, the real estate prices are really high. So apparently they don't have a separate room to do PD and so on. So those kind of challenges also exist when it comes to the Indian context in terms of PD. But like I mentioned, I think the 6 years of my life on peritoneal dialysis were the best in my entire 28 years of with kidney failure. I think the 6 years I was on PD were absolutely without doubt the best. Now, why I liked PD? It was done at home. I didn't have to visit the hospital thrice a week. There were no needles. I used to be very, very scared of those two thick needles that are inserted into the arm for hemodialysis. And I really liked the fact that in peritoneal dialysis, there were no painful needles. I found it much easier to travel on peritoneal dialysis. So all I had to do was call the company that gave me the fluids, and I would tell them that I'm going to this location, and then they would deliver those bags to the nearest city. And then I would just go pick up the bags from there and then go to the destination where I was traveling and then do my PD without any problem. So it was much, much easier to travel. On the other hand, with hemodialysis, the problem of traveling is that you need to find out a good quality dialysis center where you're going, and you need to book in advance. Plus, you don't know what kind of technicians and nurses they will have there, the what kind of protocols they follow, what kind of consumables they use. You have no idea on the quality of dialysis that is being offered at the destination that you want to travel to. So it is quite daunting to travel on hemodialysis. On hemodialysis, there are also challenges like during the dialysis session. I think anybody who's been on dialysis has probably encountered acute complications like your blood pressure suddenly becoming low, because of which you have giddiness, dizziness. You could have cramps in your feet, and a lot of complications happen on hemodialysis. There could be a blood leak and so on. There's also a risk of viral infections in hemodialysis, especially in dialysis centers where protocols are not followed very well. So there is a chance of patients getting infected with hepatitis C, hepatitis B, and HIV viruses. So I felt overall that life was more normal, than conventional HT. Now, what do I mean by normal? So when I switched to PD in 1999, within a few months, I started working part-time. I started traveling. I started playing table tennis in those days. So I found myself much more, similar to people with healthy kidneys than I was in the first 1.5 years, which were based on which I was on hospital hemodialysis. There are challenges like Dr. Sachdeva mentioned. So you need to be very diligent in doing your exchanges. You should not skip exchanges. If you've been prescribed 4 exchanges a day or 3 exchanges a day, you need to make sure that you find the time and you do it at the time that it is needed. Sterile technique is a very, very important thing in peritoneal dialysis. There's a six-step washing technique, hand washing technique that you are taught. You need to make sure that you do it. And what often happens is, while in the initial 2-3 years of peritoneal dialysis, people follow the sterile technique and so on very well, and they do their exchanges in time and so on. Over a period of time, after let's say 4 or 5 years, people do tend to become a little lax with the sterile technique and even the time of the exchanges. So if you don't follow the sterile technique, there is always a risk of a bacterial infection, and PD bacterial infections are notoriously difficult to treat. I had a major problem with my catheter in 2004 December, when I was caught in the tsunami of South India on 26th December, and my peritoneal dialysis catheter got infected. And over the next several months, we did everything possible. We antibiotics, removed the catheter, repositioned it, put in a new catheter, but those damn bacteria were almost impossible to eradicate, and because of which I had to give up PD. So bacterial infections are a big risk with PD. Of course, it can be avoided. Not everybody gets to encounter a tsunami, but if you're following the sterile techniques and so on, I think it is not impossible to stay away from bacterial infections. Like I mentioned, some people don't like the responsibility to take the whole responsibility of care into their hands. So while for me, that was not a problem, I really enjoyed the freedom that peritoneal dialysis gave me. And I was totally okay. In fact, I preferred it this way, where I was in control and I could do my treatment, myself. And, the technique fatigue sets in after a few years, and that is something that really patients need to watch out for in PD. Coming to home hemodialysis. So once I had to give up peritoneal dialysis in 2005 after getting caught in the 2004 tsunami, I was on regular hospital-based hemodialysis for about a year. My nephrologist could make out that I wasn't very happy with that therapy, because I did not have the freedom that I did while I was on PD. He suggested that I switch to daily nocturnal home hemodialysis in May 2006. And in that, what happens is you set up a machine and an RO plant at home, and you do your dialysis 5 nights a week. Now, this can vary between 4 to 6 nights, but I picked 5 nights, and then you do it for about 7.5 to 8 hours each night. So initially I was very, very kind of wary that how could hemodialysis be done at home, because you see a lot of complications happening in the center. You've gone through some of those complications yourself, and you wonder that what if such complications happen at home? There's always this worry that's there at the back of your mind. But when I read up online and I joined some support groups online of patients doing home hemodialysis, and most of these patients were from outside India. What I learned was that since you're doing it 7 to 8 hours each night and you're doing it so often, you're getting roughly about 35 to 40 hours of dialysis every week compared to the 12 hours that you would be getting in the conventional regular hospital-based hemodialysis. You're getting much more of many more hours of dialysis, which means that the dialysis can be much gentler. You could put the dialysis at a low pump speed, that is a blood flow rate, and you could be removing fluid at a much lower rate than you would in conventional hemodialysis. Just because of all these factors, the dialysis itself tends to not have as many complications. There could be once in a way you could have a little bit of complication, but it is nowhere as concerning as the complications that could happen potentially in a hospital-based setting. And so I switched to this modality in May 2006, and within 2-3 months, I started feeling much, much better. My quality of life improved significantly. I started swimming every morning. My hemoglobin just normalized without even needing any erythropoietin. I had to give up my erythropoietin because my hemoglobin just came back to normal, and then I did not need erythropoietin, as long as I was at this therapy. And then, so life was very good, and I got back to a completely normal life. I just had to make sure I did this dialysis 5 nights a week, 7 hours each night. Another change that I did recently, about 3 years back, was that I switched to daily nocturnal home HDF, which is hemodiafiltration. Probably some of you might have heard of this modality called hemodiafiltration, which is one problem with regular hemodialysis is that the modality tends to remove larger molecules, larger toxin molecules, a little less efficiently. So over a long period of time, especially in patients who've been on dialysis for long, they tend to develop complications like amyloidosis and so on, which is caused by the buildup of beta-2 microglobulin, which is a large molecule. It's called a middle molecule, but it is larger than the typical molecules that are removed by conventional hemodialysis. So hemodiafiltration tends to remove middle molecules, that is larger size molecules, much better. And I had a problem with amyloidosis, so I switched to HDF in June 2022. Thankfully, now the amyloidosis is settling. So now coming to the Indian context in terms of home hemodialysis, Dr. Sachdeva mentioned about the NX-Stage machine, which is a very nice portable machine that can be taken with you when you travel. It's very, very easy to operate. I had the fortune of using that machine when I traveled to the US last year. I used it for about a month. But it's a very, very nice machine, very convenient, and they have an excellent support system there. Unfortunately, that machine is not available in India. There is no portable machine that's available in India as of this, at this time. So what do people do? The patients who are doing home hemodialysis, what do they do? So there are again 3 different types of modalities that home hemodialysis patients in India use. One is the conventional hemodialysis, which is 2 to 3 times a week, 4 hours. Machine is typically stationed at home permanently. And then there is another option where machine is brought for treatment by a provider. Dialysis is done, and then the provider takes the machine and goes back, right? Then there is the second type of hemodialysis that is done at home is the short daily, which Dr. Sachdeva talked about. It's done typically 5 to 7 times a week, 2 to 3 hours. Again, this could vary from patient to patient, the frequency and the duration. And then there is nocturnal HD, which I do, which is 4 to 6 times a week and 6 to 8 hours. And then some people do a combination of all this with HDF. Some people would do one session of HDF, or they would do all sessions with HDF. It varies from patient to patient.
HDF again, what was the F and the
Hemodiafiltration.
Okay.
Now, one thing that I rue often when I think about home hemodialysis in India is that most people are getting the conventional hemodialysis, which is 3 times a week, 4 hours each time. Now, compared to the hospital-based conventional hemodialysis, this does not offer any clinical advantage whatsoever. So I often think that while, of course, it gives you the flexibility and the convenience of not having to go to the hospital and do it in the convenience of your home, but unfortunately, you are missing out on the huge clinical advantage that can be obtained by doing it more frequently and for a longer duration. So very few people do short daily, which is 5 to 7 times a week, 2 to 3. There's hardly anyone doing daily nocturnal, which is 4 to 6 times a week, 6 to 8 hours. And it has actually been shown in studies that daily nocturnal home hemodialysis has outcomes, which is quality of life and survival outcomes that rival that of a deceased donor kidney transplant. Now, all of you are familiar with deceased donor kidney transplants or cadaver transplants, as we call it. Just imagine this, right? That outcomes with daily nocturnal home hemodialysis rival those of deceased donor kidney transplant. This is a published study that I'm referring to. So it's a pity that people who are doing it at home don't take advantage of the flexibility and the convenience of having it at home and do more frequent, longer duration dialysis. I can very confidently say that I'm alive today only because of daily nocturnal home hemodialysis. Otherwise, I would have died long back, because I am the most non-compliant patient you will find. And I find that daily nocturnal gives me the liberty to be liberal with my diet and fluid. And plus, it gives me completely normal energy levels. So I can work full day, I can swim, I can travel, I can do things that healthy individuals can do. I think the biggest challenge in India is the lack of home machines. I think if home machines like the NX Stage become available, especially if they are portable, which would enable travel, I believe that a lot more people would actually opt for home hemodialysis and get the advantage and the benefits of more frequent, longer duration dialysis. So to summarize, I think both home hemo and PD offer much more flexibility. They are much more, normal. Patients can have a much more normal life compared to in-center or hospital-based hemodialysis or hospital-based hemodialysis. One thing that needs to definitely be changed is that we need to somehow bring in the concept of making patients be aware of all the options, and that can only be that can only happen if more and more people, more and more doctors take it upon themselves to, if they don't have the time, at least get somebody in their team to counsel and make patients aware of all the options and mention all the options that are there. That is hospital-based hemodialysis, short daily home hemodialysis, daily nocturnal home hemodialysis, peritoneal dialysis, kidney transplant, and even conservative care or palliative care. Because some people, let's say the elderly or even people who are tired of their therapy, they may not have the energy or the willingness to go through dialysis, and dialysis is not pleasant. So people must be told about conservative care also, and I'm sure that's a topic for another day. But what point I'm trying to make is inform patients of all the options, give them the pros and the cons of each, and then let them be a part of the decision. They are the most important stakeholders. Doctors are not the ones that can decide that this patient is going to do HD and this one is going to do home HD and that one is going to do PD. Talk to the patients and let them be a part of that decision. Let them take the decision. One challenge is that home therapies are not covered by most insurance companies. Unfortunately, that's one big impediment in India. Uh, and even though it is also proven that if a patient is on home therapies, the long-term costs to the health system are also lower in terms of hospitalization rates and other things. So it is better for the insurance companies in the long run to look at that and to cover home therapies so that their overall cost on that patient over a period of time is going to be much lower. Government schemes, again, do not cover home therapies, unfortunately. So that's that's all I had to share. But I hope you all took away the key points. And if you have any questions, maybe we can take them. Pallavi, over to you.
Thank you so much. If you can, Malaysia. I just want to ask you, Kamal, if you know on a roughly how many people really are doing dialysis in our country?
The number of dialysis patients.
A number of people who have chosen home dialysis as an option.
Home dialysis, it's a minuscule number, Pallavi. I would assume it's in the single digit percentage, about maybe 2% or 3% or even less than that. It's very, very low. Probably around 2% is what I would guess.
There are some questions. Thiagu, do you want to unmute yourself and ask your question? Are you there? Yogita, can people unmute themselves?
Yes, ma'am.
Okay. So, Thiagu, you had some questions you want to ask them on your own? Should I read them out? Okay. So, he wants to know which is a better option, hemodialysis or CAPD in terms of efficiency or effective clearance. I don't know what that means.
Maybe
Mala,
Dr.
would you like
Sachdeva
to
can
answer?
take that. Yeah.
So the question is between in-center hemodialysis and home dialysis, right? And, I think we talked about all the benefits of home dialysis, right? The quality of life, the survival, the medical benefits, the benefits of doing it at home. But I think the biggest question, and then also the survival benefits also of both nocturnal hemodialysis, right? And peritoneal dialysis itself, the first 3 years. I think the biggest thing is, choosing the modality between the patient and the physician of what fits the patient the best. But I do think that, like Kamal was saying, I think every patient should be aware of all the home modality options. And I think that should actually be a first choice for a lot of patients, as opposed to in-center hemodialysis. If home modalities fail, then go for the in-center. But a lot of times I think you have to discuss, the physician and the patient have to discuss with the patient what fits their quality of life and what they prefer.
You change that, Kamal. I heard you saying that just not offered peritoneal dialysis is simply not even an option that's given. So why is that happening, and how can we really change that?
So, unfortunately, what happens, Pallavi, in many cases is that, like I mentioned, patients crash land into end-stage kidney failure, right? They don't know that they have kidney failure until they reach the stage when they need some therapy. Now, in many cases, it's easier to get somebody onto hemodialysis because you put in the catheter and then you can do dialysis the same day. In peritoneal dialysis also, these days they do offer where, within a day or two, I think, of putting in the catheter, they use a cycler and they make them lie down and do exchanges. But these are all things that are not very well known or popular among nephrologists. So for nephrologists, I think they're just more comfortable with hemodialysis, unfortunately. And some doctors have also told me that PD is not that much of a focus even during their courses, their degree or their program, their MBBS and so, I mean, sorry, their nephrology programs. It's not does not receive that much attention. There is not much of practical training that they get. So doctors are just because of that, they are a little possibly a little more comfortable with hemo. It is a known devil compared to peritoneal dialysis. So that's possibly one of the reasons. Another reason is physician reimbursement. Reimbursement rates for peritoneal dialysis are far, far, far less than hemodialysis. So that could be one of the reasons as well. Plus, doctors, honestly, the doctor to patient ratio is very poor in nephrologists to patients in India. So
yes,
doctors don't have the time
lay out
to
all the
actually do
options.
that. Yeah.
Really, do you want to unmute yourself and ask your question?
So it was a nice presentation, a lot of the inputs. So I just want to manage if a patient gets a complication in between the dialysis, how will they manage, like hypoglycemia, hypotension? How will they manage?
Dr. Sachdeva, you want to take that?
Sure. So the hypoglycemia probably is not going to happen on peritoneal dialysis because a lot of the solutions have glucose in them. And the patients, in fact, their glucose can go up and they're taught how to manage that part of it. With hemodialysis, I mean, the complications of hypotension can happen, with peritoneal dialysis at the end of the cycles or with hemodialysis itself. But it's less frequent than with in-center hemodialysis. And the reason being on home therapies, it's less frequent is because these therapies are more gentle, done over a longer period of time. And in the setting of the home hemodialysis, it's with lower blood flow rates. So it's just more gentle and longer dialysis sessions that you're giving the patients. So it's encountered less often, but if the patients are experiencing it, they are 100% taught what to do in those settings, and they're able to deal with it. In the past 15 to 20 years, including the fellowship that I've had, I've never had a patient who ended up having any type of huge complication from being hypotensive on dialysis. And the hypoglycemia is hardly encountered.
Okay,
just
okay,
to-
thank you.
Just to add to the on the Indian context, right? One thing that I probably forgot to mention is that all home hemodialysis in India is assisted. No patient in India is doing it on their own. Either in most 99% of the home hemodialysis in India is administered by a technician. There are a few people who do their cannulation, but the machine and stuff is managed by a technician.
Including for you?
Yes, including for me. I do my own.
And that's not
cannulation,
true
but
outside, Mala?
No, in the US, Australia, it is always the patient themselves do it, or they would have a spouse or a family member or somebody do it.
They have to find their own caregiver, or they pay their own caregiver, and I think that is one of the biggest hurdles that we have of putting patients on either peritoneal or home hemodialysis is the lack of a caregiver sometimes, especially as patients get older and they can't do these things themselves. But other than that, here are patients, because that is not like having a technician come to the house is not covered by insurance. It's not covered at all, and it comes out of pocket, which can become very, very expensive for the patient.
Yeah,
So
but
what is the percentage of, sorry.
In India, the costs, the labor costs are significantly lower than in the US. So that becomes possible in India, because of which home hemodialysis is growing steadily. Please go ahead, Trilly, sorry.
I was asking, what is the percentage of